them in turn, and those that are here will come up and take a seat. Those that are not will be online. And the first person is online is Ms. Fulvia Raffaelli, who's the head of digital health unit at the European Commission, DG SANTE. Patrick Breyer, who's a member of the European Parliament and the European Health Data Space LIBE Shadow Rapporteur, and is a Green from Germany, will be joining us at 2. Pernille Weiss, on the other hand, who's a member of the European Parliament and the Environment and Public Health Committee, and a member of the Danish centre-right EPP, is here. So I'd ask Ms. Weiss if she could to come up and join me on the panel. Ah, well. I didn't see you. Crept out. If you want to come over here.
Where? Here?
Yeah. And then we have Dr. Jørgen Schøler Kristensen. I hope I pronounced that right.
Perfect.
Who's the head of corporate management, the Central Denmark region, chairman of Danish Medicines Council, which is the national HTA body, and former chief medical officer of Aarhus University Hospital. And he's the Danish H2O representative. So welcome. And then we have Dr. Peter Gorka, head of digital health and data network of the European University Hospital Alliance, and Chief Digital Officer at Charité Universitätsmedizin Berlin. Welcome. And Valentina Stramilio, who's the Director of Programs at the European Patient Forum. Welcome. And then last but not least, we have Mene Stiliadou, who, as you've heard already, is H2O co-lead and Distinguished Fellow Data Science Institute at Takeda Pharmaceutical. So as I mentioned, this is going to be a panel looking at patient-centered partnerships and bringing the health data space to life. So really, one of the key questions, if we talk about H2O and the health data space, is how actually do they interact? And we touched on that in the first panel, but I'm going to turn to Mene to kick us off on that.
Thank you, Elaine. I think first we should also welcome MEP Mr. Breyer, who is in the meanwhile.
Oh, he's already here. Sorry,
we
Mr.
thought
Breyer.
it would be late. So we should, thanks very much for joining us. So yes, so H2O was created mainly and primarily to empower patients, to give patients the possibility to measure their outcomes in a structured way, in a standardized way, be able to use this in collaboration with the clinicians, very much along the lines of what we had this morning. So this is the primary and the most important objective of the H2O. Now, to make this happen, you need to also create a governance around the data. Where will the data go? How will the data be managed? How are we going to create the trust so that the patients actually measure their outcomes and share their data in the way that will allow the primary objective to be achieved? So the governance became the secondary objective, if you want, of the H2O. And we started thinking about it, I think, 4 or 5 years ago. And what we came to understand is that we need to build a governance that builds on the principle that health data is an essential resource. And what does this mean to us is that once the patient gives their consent, which of course is it's the first thing that needs to happen, nobody else should actually be deriving power or control over the data. So the data should be managed, and that's why we call the project H2O, like water, should be managed as an essential resource in the interest of society, in the interest of patients, in the interest of science. And that's what we said. What we are putting together is a governance with similar, it's a non-for-profit organization whose mandate and focus is to ensure that the data is being governed in the interest of the society. So any queries into the data will have to be ethically approved. We'll have through an independent board. We spend a lot of time thinking and introducing this concept of multi-stakeholder board that will have the responsibility for agreeing to these queries into the data. And in that way, we hope we will create the trust with the patients that will help us to create this treasure trove that Elena was talking about earlier and unleash the potential of health data. So when the EHDS was published a few months ago, it was such a wonderful development, because if anything, it endorsed the principles that we've already been advocating for a number of years. So once EHDS is in place, then, and the EHDS authorities are going to be in place, which the model is very similar to what we are talking about. So once these authorities are in place, probably we don't need to do the ethical scrutiny anymore, right? It will come straight from the ethicist, so less work for us. The primary objective, however, of the H2O remains. And the primary objective of the H2O is to create this trust among the patients and allow the standardized way of measuring the outcomes in a way that will make sense for science, for patients, for society, etc. So in the meanwhile, and as we are building up to the EHDS, we will probably building up some very interesting experience and precedents and frameworks that would potentially build the framework for EHDS and can actually be useful for the EHDS. So I think we are a live experiment of what the EHDS could become. And potentially and hopefully we will become a major data holder that will be contributing data into the broader EHDS environment.
Super, thank you very much for that. I should just say that as per this morning, you have the ability to ask some questions via Slido, and the QR code was been flashing up behind me. So please do take the opportunity to do that, or else use a link, or if you're in the room here, then we have mics as well. So just to, whilst we go through the panel, we'll come to some Q&As as they come up. So moving on from Manny's introduction there, I'd like to ask Ms. Raffaelli from DG SANTE, do you believe that the European Health Data Space will deliver? It's a big question.
Well, yes.
Good answer.
That's the short answer to your question. Yes, we believe that this is going to become a reality, and actually it will also deliver, hopefully, on the benefits for the patients and for the citizens of the EU. We know this is a very ambitious project. We are fully aware that we'll have to work with all of you, but we also believe that the benefits will be huge. Our vision is that on primary use side, the EHDS will eventually bring better health outcomes for people. Health professionals will have a better evidence basis for treatment, and patients won't have to repeatedly explain to their medical history and provide documentation. This means a better quality of life for people in Europe. We'll see a reduction of unnecessary repeated tests, and thus significant savings for patients and healthcare systems. And we have estimated this to 5.5 billion of saving over 10 years. We also have better transparency for patients over their health data, and finally control. And we will be able, each one of us will be finally able to control which healthcare providers has which information about myself, and who has looked at those. On the secondary use, we hope to see a new and innovative medicines and devices thanks to the greater availability of electronic health data for researchers and innovation. And we also see, hopefully, a better, easier access for regulators and policymakers to crucial public health data, so that in the unfortunate case of a new pandemic or other public health emergency, they can take the right decision at the right time. But also, more data will allow authorities to design more evidence-based public health policies in the medium-long term. And in this area, we estimate the economic benefits of the secondary use side to up to 5.4 billion over the next 10 years. But on this, I'm very much with you, with the previous speaker, saying that the trust is really the key words for that the EHDS be able to deliver on its objectives. It will deliver only if the citizens and the healthcare providers would believe in it. And that's why we have introduced a number of safeguards, information security and privacy. We are working closely with the member states, drawing upon their experience in digitizing their healthcare systems and supporting them along their way. We will introduce very stringent safeguards on primary use. We will have, for example, specific security requirement for electronic health record systems, and the exchanges of patient data, for example, or patient summaries of e-prescriptions can only happen when there is a care relation between the health provider and the patient. And I think in this area, we fully align with the ethical principles that were referred before. The health professionals will have to identify themselves securely. And on secondary use, and here we're even more closer to the result of your work, we have clear lists of allowed and banned purposes. By default, only anonymized data will be made available where answering at specific research questions in secure processing environment. Researchers will not be able to export to the pseudonymized data from the secure environment, only anonymized result. So yes, the EHDS is very ambitious, but we're working with the member states and with all the different actors involved in the system. We know they will need time and financial support, and this is why we have proposed a transition period with staggered implementation and significant financial support. So yes, again, I believe the EHDS will become a reality and will deliver significant benefits for all of us. Thank you, and over to you.
Thank you very much. I just had one follow-up question, because obviously we are in an EU of 27. To what extent can one be prescriptive on a health data space, and in regard to, in particular, who can access the data? Are there different views across the EU 27, for instance, if one has to pay, and if different actors have to pay more or less? Or is it like H2O, i.e. it's a public access issue and everybody should have the same access to the data if used properly?
Well, this is indeed one of the objectives of the EHDS proposal, is going beyond the current regulatory approaches based on the GDPR that actually allow patients to require their own data, all kind of data, so not only health data, within 30 days, and with some possibilities for the data holders actually to impose fees. The EHDS in this case goes beyond this obligation and foresee a rights for the citizens to get access to their data immediately and free of charge. This is because, of course, of the in-depth digitalization of all the health data that we are promoting via the setting up of the EHDS. So once the data will be available on a digital format, then the access will be is expected to be indeed immediate and free of charge. So I hope this, I'm sure this will become reality.
Yes, that's obviously very comforting and obviously quite basic for a patient. But what about other actors that would want to have access to the data, be the public researchers versus, private actors like pharmaceutical companies or researchers in that sense? Is it envisaged that there will be payment for access, or will it be free access according to what they're trying to achieve, i.e. they're trying to do something for public health?
There will be a possibility to impose fees. For this we rely on the same rules that are drafted into the GDPR general horizontal regulation for the access to data. But actually the structure is very similar to the one that has been described. The governance of the system for the secondary use is very similar to the one that has been described just before in your project, because this research innovator will have to prepare an application, introduce the application that would then be assessed by the health data access bodies, which are nationally based, and that will rely on common guidelines, but then will also keep somehow their national sensitiveness in relation to the access to data. and the researchers innovator will only have access to those data once the access has been granted. So yes, there will be a possibility to impose fees, and that based also on the on the quality of data required, on the extent of those data, and of the final objectives. Again, in line with what already foreseen into the horizontal regulation for access to data.
Yeah, and I had a question as well around the EHDS to ensure data and anonymization by default for secondary use. Does that not threaten data quality and data utility? And how does H2O address this? That's more for you, actually.
How will, I think there's a bit of confusion there, because first the question is about the EHDS and then it goes about H2O. Yeah. So what do you want me to answer?
Well, you on H2O and Ms. Raffaelli on EHDS. So it's about anonymization of use of data.
I think the anonymization, at least in the H2O world, the anonymization is going to, I don't think it will affect the data quality or the data utility. You have to anonymize the data in order to be able to do any secondary use of the data. I think that is a fundamental principle, unless, of course, and there are some type of situations where the patients are okay with personalized data being used, because if it is about their personal care, then it is personalized data that will be used. But I can't quite see why the anonymization will reduce the quality or the utility. Of course, if you do an if you do an aggregation, so you bring the data down to a dashboard, yes, then you do reduce. But an anonymization where you just make sure that no cell, I heard it, this is the rule in Denmark, that you never see any cell with less than 5 patients. I think that type of anonymization is the way we will combine.
So it's getting the right definition of anonymization. In order to be the right quality and the right protection.
Yeah, and
maybe I could just turn to you, Dr. Gocka. Maybe from the point of view, again, we've heard from the top down, the European level, about the EHDS and why it will make sense. Maybe you can tell us from on the ground, what would you want from the EHDS in terms of a framework, a legal framework?
So I fully agree with the opinion that the EHDS will deliver. If you see at the need that it tackles, it has to deliver. And medicine, for sure, and for long years now, is a data-driven profession, and data needs a home. And if you look at the healthcare systems, they are more or less fragmented on national basis, on regional views, even in hospitals. And in most industry, overcoming fragmentation is done by use of digital platforms. And EHDS is a very suitable platform for do this, for care delivery on the one hand side, but also for research. And research really consumes huge amounts of data, needs huge amounts of data to create knowledge. And we don't want to hand over our data to US-based cloud structures, which are capitalism-driven, or to Asian ones that are state interest-driven. So we really need this EHDS to have a platform to work for a healthcare system that is made in Europe for European citizens.
Thank you very much. Maybe I could turn to our 2 parliamentarians. Maybe Mr. Breyer online. What's your view of the European Parliament view from your perspective on the likelihood of the European health data space delivering on its ambitions?
Yes, good afternoon, everybody, and thank you for inviting me. Now, from my perspective, and I've been active in the on the topic of civil liberties and fundamental rights for a long time. I want to start by pointing out that health data is not a commodity that's open for exploitation for all kinds of purposes. But this is extremely sensitive, personal, and intimate data. Think of psychological treatments and the like. And people may no longer want to seek treatment if they can't trust in full confidentiality of what they disclose in those settings. And if they lose that trust and don't no longer seek treatment, they will endanger themselves and the people around them. And therefore, the expectation of citizens is that the information about their health and conditions and mental and physical health is treated with utmost confidentiality and respect. So ensuring a secure system and that the patient is in full control will be imperative when it comes to citizens' willingness to opt in to a digital health record and also maybe to sharing data. And for this trust to be achieved, we need to make sure that there is security by default, that there is sufficient literacy also, transparency, control for the patient, and all of these elements are either missing or insufficiently addressed by the proposal that is on the table. So first of all, when it comes to what happens to the data, who has access, and who is it shared with, the patient's consent must be a precondition, both for having their data made remotely accessible in the first place beyond the treatment providers they have chosen to trust, and also for granting access to other treatment providers to this information. So without the free consent of the patient, the treatment information should only be stored locally by the chosen doctor and not automatically be made remotely accessible, where patients can no longer trust that they are in full control. Remote access opens up additional risks of data loss, and having these in a single data space, even if it's a federated system, can result in security errors, making losing the entire data of thousands and millions of people. Also, only the attending physician should have access to their own treatment information unless the patient freely consents in other treatment providers accessing this. That includes the fact that a person is being treated by two treatment providers at all. There are good reasons that a patient, for example, wants to obtain a second opinion without the first treatment provider knowing about it, and we should respect this. When it then comes to the secondary use, so for instance, for research or governmental purposes, if ever there is to be such data sharing without specific consent in the specific use and research project, then it can only apply to anonymized and aggregated data, as has been discussed earlier. And this should not only be the principle, but should apply generally. As has been said in this panel, this information is sufficient. And it's not sufficient to simply remove the names of patients, because the treatment histories are so unique that it's easy to reassign them to the patient in question. And that's where I also find this project at hand, the H2O project, interesting, because I understand that you seek to anonymize health data, and indeed the aims that you are pursuing can to a huge degree be achieved with anonymized data. So more broadly spoken, the proposal should establish clear rules on transparency. It should address conflicts of interests, both for stakeholder engagement, but also within the responsible national authorities, including a consultation process with all relevant stakeholders. And when it comes to the issue of security, IT security, the standardization is pivotal for data protection, preventing discrimination, and that's also where conformity assessments, mandatory conformity assessments, need to come in. And finally, regarding the government's and enforcement of rules and the system. Adopting strong rules, of course, is only the first step, but it's equally important to make sure that they are observed. And so, for example, the data protection authorities need to have a permanent seat in the board. A stakeholder participation needs to be clear. We can't have a structured participation of industry in stakeholder fora. Here, a talk invitation should suffice. Now, regarding all of these points, the discussions in the European Parliament haven't even really started, apart from the presentation of the proposal. And it's impossible to say at this stage which of these issues and requirements will be addressed efficiently. But it is clear that for both European Parliament committees that are involved in civil liberties and the ENVI committee, that colleagues are aware and considerate of these issues and their importance, and also that many stakeholders are on our side when it comes to defending the patient's rights. And I think there is a general agreement that patients and their right to self-determination must be at the heart of this new regulation.
Thank you, Mr. Breyer. I'm going to turn to your colleague, Ms. Weiss, in a minute. But I just wonder if there's any reactions to some of the points that Mr. Breyer has made. I would pick out what he said. Well, what he said was that he's very much in praise of the H2O project, which is good news. And he sees a lot of convergence in terms of the way you're setting things up in terms of standards, etc. But there was a strong call there for data localization. So I wonder how that works in a pan-European model. And one other thing that obviously stands out is this issue of governance and keeping industry, as I understand it, out of the governance. So how would that work with the model that you're putting forward in H2O, Mr. Gokka, for instance?
Well, with regard to the second question, localization, in Germany, we have a long tradition in federated data use, if any. Mm-hmm. And of course, we know about the weaknesses of this approach. So our proposal would be to have some data at least available centrally, at least metadata. Mm-hmm. And of course, then you can give access to federated localized data. But we should not let the fear of data misuse dominate the models in that we use data, because it's also unethical not to use data to care for patients. And it was mentioned that privacy officers should be part of the board for any decision. Patients should be there too, because what we are doing is deliver something for patients, not for us, unless we became patients. But the patient should be at the center, even of the decision, who can access his data in what way. And I don't want to have and create a system that forces a patient to hand his data over to Google or others just to get use back of that data, because we fail to deliver a system and that data can be used properly.
Thank you. And Dr. Schøler?
Yes, I agree with you, Peter. And coming from Denmark, where we have a long-standing tradition for collecting data for the country, for the cohort, we actually created the Danish population as a cohort. We have centralized the data in the National Data Authority. They're running, I think, 24 different data spaces, and they're national. And we've had a huge discussion taking years, but the population is not, the citizens are not against, as long as they can see the purpose for their healthcare. And the scientists, of course, are lucky. I heard before somebody saying it's really easy in Denmark and the Netherlands. If you ask the Danish scientists, they'll say it's really difficult. But we acknowledge that we have the national databases. There's still the GDPR, which are not that problematic. You just have to learn them by heart. And then the second question about industry and companies. I'm not sure that we can exploit the data creating knowledge alone as the healthcare system. I do not think that's possible. We have to invite others who have other competences into the game of creating health for citizens. So I'm pro companies because in the proper way, we all benefit from it.
Super. Manny, did you have
Yeah,
a
it would may not be appropriate for me to take a position, but what I think I can say is the rationale of the way we put the governance model in place. So in putting the governance model for the observatories in place, we thought that we need to build trust. And if we can only really have trust if we have independence. And we will only have independence if we have sustainability. And that's some experience that I also bring from other work I've done in the past in my life in a completely different sector. But you cannot really have a truly trusted stakeholder body that takes decisions in a way that's really trusted by the society, by the overall society, unless on one hand, they reflect everybody's points of view, multi-stakeholder, and secondly, they don't depend on anybody for their funding. So the moment that you have a body which is fully dependent on the government for their funding, there is a bias. The moment that you have a body that's truly only dependent on the private sector for their funding, there is a bias. But if you have a body that has a model that allows the long-term sustainability in a non-for-profit manner, but allows this long-term sustainability, then they can become really independent. And they can be the place where all these multi-stakeholders kind of find a way to reach a consensus among each other. But if you want to enter into the sustainability discussion, then the private sector has knowledge to bring in. And the way we've done it is that nobody in our board has majority. So it's a 5-members board with the 5 stakeholders being equally represented. And when it comes to the pan-European board, there actually we don't have the private sector. It's only the national observatories which are part, plus 20% the pan-Europe, the EPF, the patient organizations, and the public sector. So, but we think that participation is actually important for the sustainability.
Thank you. Ms. Weiss, we've had one point of view from the European Parliament, and as Mr. Breyer said, you've still got to get into the actual discussions, but perhaps you could give us a point of view from EPP, if we could be so.
Sure, sure, yeah, because we are politicians, so we speak also from our values and our ideologies, some more than others do. I try to add the perspective to my policy, and I find it echoing a lot on the EPP position that I'm educated as a nurse. My grandmother was a nurse. My mother was a nurse. I was a nurse, and I have also other experiences in healthcare, and also as being one of the private enterprises working on healthcare. So I echo very much the need for a sustainable approach, but also an approach that builds furthermore the trust and understanding in between us as citizens that we cannot get the help that we need in our lives, facing either a diagnosis or at least healthcare, health-related issues, if we don't communicate with professionals. And they cannot help us if we don't help the professional ecosystems in medical industries, in pharma industry, in social science, whatever, because we need a holistical, patient-centered, personalized approach in the future. I think because we get fewer and fewer, older and older, and also fatter and fatter as Europeans, that's a fact. So we really have to co-create with each other, and there the health data space can be a platform for that in order to make Europe stay as rich and innovative and peaceful and healthy and prosperous as it used to be, and as it is now facing many challenges to continue to be. And therefore also seen from an ENVI point of view, because it is a shared responsibility between LIBE and ENVI to make the European Parliament's contribution to the design of the health data space legal framework and details within that. I also try to foster with my colleagues, and is especially the point of view from EPP, maybe more than my colleague from the Greens, although I also see that there is a holistic approach coming from all political groups in the parliament. But I'm a little disappointed that the ITRA perspective, the industry and innovation perspective to the health data space is not given more voice in the co-creative work of us politicians, because it's so important that we cannot as citizens get the help we need if we don't communicate with the professionals. They cannot create the mix of treatments and whatever we need if there is not innovation and research and also business development with the industries of different sizes. And if we miss that opportunity and that perspective, having a blind eye to research and industry policy related aspects of how we design the health data space in Europe, we will, as we see in many other industrial ecosystems where we as citizens rely upon the fact that we can also get more and hopefully soon 100% either green or at least clean energy that doesn't pollute the environment and our climate, by the way we design the business opportunities for the energy sector, then the investments and all the bright heads and good hands to provide us the Europe we would like, they go abroad. I mean, investors don't invest right now that much in the green transition in Europe because we have failed by being this regulatory monster, not also inviting more co-creativeness without damaging the trust. Of course, confidentiality and trust is pivotal, but we are right now also facing that we could design from the European Parliament. I hope that my colleague agrees that we should try to put forward a proposal that also makes Europe attractive for every kind of health-related research and development, also industry-related research and development in the future, because otherwise we will not give the professionals the tools, the medicines, the treatments they need to be able to give to the patients when the patients come and say, hey, see, this is my data. I think we can improve my patient plan, my treatment plan, my whatever it is, if we do not have also a good and healthy and trustworthy, innovative cooperation with the industry and the research environment that are both private, public in Europe. Otherwise, the industry, the investments, the researchers, our kids that go to school and get the bright heads, they will go to US instead. Where to unleash their intellectual potential, and thereby we will not in Europe make the healthcare grow in the spirit of the European values of integrity, dignity, freedom of speech, freedom to live our lives as we want, etc., etc. So sorry for putting it up on that or that down in that fundamental parts of how it is to be a European. But that is also where I hope, and congratulations with the launch today, that H2O, I'm actually a chairman of what is called MedWater. So I love analogies and strong metaphors. So I really hope that you can help us to create a safety net of policy that combines the patient perspective, the professional's perspective, and then, if I may be so simple in my choice of wording, market approach to how to design the health data space in a way that it really fosters research and development. Because how fun is it to be able to look into some data that are mine, knowing that all the good treatment and diagnostic is happening elsewhere than in Europe, because of the way that we made it difficult for us to work with our data in, of course, a trustworthy, anonymous, and relevant way. So that is my take, and I think I speak on behalf of EPP on that. I have a very, very clever colleague who is the co-rapporteur with the LIBE ID rapporteur. So that also will bring up maybe some interesting political debates in the committees and also further on in the plenary work on that. So sorry for being so lengthy. I'm not from Germany, although I have a German surname, but I have the tendency to speak just as long as sometimes Germans do.
I'm glad to have you here.
Thank you.
Not a problem. I don't know, Ms. Breyer, if you had some further thoughts, or especially as concerns the issue of all stakeholders being involved. I think particularly industry to take hold of the opportunities that the health data space will offer.
Yes, thank you for giving me the floor. First of all, I'm looking forward to working with my colleague, and we'll be having the first meeting soon. And I think we will have a good discussion and debates on this really important file. When I talked about what you called data localization, many things are understood as data localization, but my point was it should be every patient's decision on whether or not their data should be in the EHDS, so in a European data space. You know, the arguments for the proposal is patients can access their data, they can use cross-border health services, but then it should be for everyone to decide, do they want this? Is this worth the risks that they take? And as for the issue of is it ethical or unethical not to use data, I think this should be for every patient to decide. We need to respect their will, and we need to respect different opinions. Some may think this, some may want it that way. Nobody should say they know better than the patient concerned what is right for them. As for Google, because that has been mentioned, of course, if you work in privacy law, you always hear the argument, you know, there is zero privacy anyway, people do anything on Facebook, but you know, all this is voluntary. My grandmother may have to seek treatment, but she's certainly not using Google or Facebook. So this is different to the EHDS. It's not a voluntary system. And just about the Danish system, and there are many similar systems in place in several other member states, this is completely untouched by the EHDS. The EHDS will be a European layer on top of the national systems. You can continue to use centralized systems if you have them in place, if you're happy with that. We're discussing here only the European layer, and that's a layer that needs to work for all. That needs to work for all the different traditions that we see in Europe. And finally, because you asked about innovation and research, and my colleague pointed that out, I think that making available anonymized and aggregated data, such as is the purpose of this H2O project, can go a really long way beyond what's possible so far. We can go even further based on consent when it comes to studies, to representative studies, using even personal data, maybe only pseudonymized personal data. So I think for the great majority of studies, it will be totally sufficient to have representative data sets. You don't need the data of the entire population. And I could also imagine that we might use the EHDS or those people that choose to participate in it to find people who you would want to invite to participate in a study. So we could do that without disclosing their data. We could ask patients, you know, you are interesting to this project. This is what it's about. Would you be interested to participate? Usually people, it's hard to even find people who you should ask for their consent. And let me just close by saying the EU is strong because of the fundamental rights and the values such as privacy that we have in place. This is something that the United States doesn't have in this way, and we should be proud of it. This is why we are strong, not despite of it. The GDPR, the data protection regulation, has become a global gold standard. Many have followed us here. And also in the health data, we should strive to be the best, not necessarily the fastest. I'm sure others will do that without respect, with less respect for fundamental rights, China, etc. We should be the best and set the highest standards, and I'm confident that we can do that.
Thank you. I see Ms. Weiss would like to go back. We've been talking a lot about the patient. So what I'd like to do now, and we can come back to some of these other issues, I'd like to ask you about, from a patient point of view, what you're expecting out of the EHDS and how HTO can help in that respect as well.
So as it has been said, we see a lot of synergies between H2O and the EHDS proposal. The first and most important point is H2O already considering having on board patients as part of the H2O boards. This is really key because, and not just because of the principle, but for patient engagement to be effective and meaningful, we need patients to be involved since the very early stages of decision-making processes. And because that's the only way they can really inform, in this case, the data pathways, make sure that infrastructure are user-friendly. And there are a lot of elements that sitting on the board, patients will be able to contribute to and make sure that the delivery will be in line with patients' needs. So I agree it's important in principle, but it's also a very pragmatic point that we need to address here. Another element, I think, is H2O is looking very closely at the data protection aspects, transparency, of course, data security, and the need to build trust. We know as a consortium in H2O that, first of all, we need to buy patients' trust if you want this initiative to be successful. And in this way, I think we have started this process because we have built multiple avenues to bring on board patients from the European level, the national level, local level. And we know that we need all these diverse perspectives on board to make sure that H2O can really meet their needs. We are very much aware that there is not just one patient's voice. There are multiple patients' voices depending on their diseases. They can be rare or common. There are a lot of diversities across countries. They can be cultural or religious. So all of this needs to be taken into account and synthesized into a perspective that can make sense to all patients in Europe. So I see H2O is going to deliver. It's not going to be easy because we want to be ambitious. But it, as also many said, it has a potential to test what EHDS will have to implement. So I see it as a very good testing platform. And I hope all partners and also the ecosystem can contribute.
Thank you. I wonder, Dr. Gorka, if you from the University Hospital Alliance point of view had something to add about the patient perspective on the EHDS and how HTO can help us get there.
Yeah, the UA is an alliance of now 10 European University Hospitals, and we also have the need for more patient engagement. So, as mentioned before, we all need sensitive data from patients for care and for research. And we only can have this data if the patient has trust in us, first-hand side, and then in the structures where we deliver those data or we share with us. So that's the reason why we are really engaged as a stakeholder in the TEDAS project towards the European Health Data Space, because we really need a sustainable system that works for every patient in Europe on the same level. And if patients move around, we do not want them to export and import data to different systems. We want to make a European-wide use of data. That's why we created a position paper, which was released last week, I think, that we really should strive not to stay in our local systems or national systems, but really to join forces in a European-wide system. So for me, I don't need data in my hospital, in my silo. I really need it in a European structure where everybody who can have access can make appropriate use of it. especially the patient, but of course also industry. Development in medicine was definitely not possible without the involvement of industry in the past 200 years. So we always had them as partners in the process of creating a better medicine, and of definitely we do not want just to hand over patient data to industry. That's not the case. But we need them in those systems to take part in the development of medicine. And as the university hospitals, we added some section in the paper that we would like to act as a custodian for the patient's privacy and his data in those environments.
Right. And I think the next question I think was related, so maybe you've covered it already, but as medical practitioners, what is it that the EHDS and HTO can bring? Because I think probably in the past, the medical practitioners, the white coat syndrome, they used to call it, medical practitioners were very much king. Does this undermine the medical practitioner's sort of status, or does it help in the end?
I think medicine will be more democratized. So patients have eye-level access to that information. If you look at the past 20 years, physicians' offices got their IT system, hospitals got their IT systems, insurance companies have them, but the patient has no IT system to take part in a digital medicine. So we need a system for him where he can take part and can accept results, get results. And that's, for me, the charm of first inside projects like the H2O, and second, like the EHDS. We need those systems. And if you look at data management in hospitals today, that's a nightmare. So many sources where different information has to be brought together for patient care that is so time consuming and so error prone. We really need more or less one source of truth. That's why we need more, at least regional, and even better national or European-wide systems.
Thank you. And perhaps I could ask you, Dr. Schøler Kristensen, because apart from the Danish H2, I understand you've got a pan-European role as well in terms of the project, and how that EHDS interrelates with that would be quite interesting.
Yes, and we are glad to be part of the H2O and have role about the Pan-European Observatory. And I agree with you, Peter, that in the future, the patient will actually need to have their kind of personalized EHR on their smartphone. Yeah. We kind of moving away from the day that you need to go to your physician, make an appointment, wait a little bit of time, perhaps talk for 10 minutes how you are and explain it from the beginning, and then discuss advising for 5 minutes. That's not the future. The future will be, I want to access the information, the advice about my healthcare. It needs to be data-driven, evidence-based. It should be high quality. It should be from my preferred healthcare provider. It should be trustable. It should be digitally. I would like to access it during the night. And we have had some trials just to let the patients access our system 24 hours a day. And as clinicians, we were really afraid that giving the access to patients would make them phone, mail us all the time. What happens? Nothing. They're very polite. They do not disturb the nurses and the doctors during the nighttime. They wait until. So I think we should kind of take more patients into this consideration.
Yeah.
They're really valuable. And I think they know best about their healthcare.
Yeah.
We're not using that information enough.
No. And as medical practitioners, the same question as to Dr. Gawker, how do you find it in terms of changing your role or your perspective as a medical practitioner?
When I was a resident, the ultimate goal was the informed patient to work with. And during the past 2 decades, we didn't deliver. But with mechanisms like those approaches, have the patient file on the smartphone at your access. That will first time be a patient that can discuss at least a bit on eye level and really take part and be engaged, and not only an object. In the healthcare systems of the past, even in our IT systems, the patient was an object that we deal with. But the patient is a subject and has to be treated as a subject. And that's why we need to change the system. That's why I'm glad to have those technology available to work on better involvement and engagement with patients.
Yeah, thank you. We've got a number of questions here that have come in. There's one on standards. So who would lead the creation of the health data standards, and how can H2O help encourage its adoption, those standards adoption? I don't know if Ms. Raffaelli, you have a point of view on that.
Yes, thank you. The standards and all the let's say all the technological discussions that are supporting the implementation of the future system HD are actually happening already in several actions, joint actions, and projecting that we're managing together with the member states and several stakeholders. So the conversation around what the best format for those standards will be in the future is ongoing, and we are trying to catch the expertise from all where the expertise is. So we do not intend to reinvent the wheel. We will, of course, consider the ongoing existing experiences in these areas, and looking together with the communities that will be involved in this exercise to define together what the future best standards would be in these areas.
So, I mean, obviously, you said standards in the rule book is central to the H2O.
Yeah, but I think the standards that are mentioned here are more technology standards. And so this is not, it's an area where we do exactly the same. So we are focusing on what is available. I think the one thing that in our discussions became very clear is the importance of standards, and I'm not sure if I'm using the right word, for cybersecurity. Because one of the things that has come to our attention, because we are not building a technology, H2O is not a technology, it's rules of the game. And one of the rules of the game that we have to think about is how we're going to partner with the various technology partners who are out there and who satisfy a certain level of cybersecurity. And then what has come to our attention is that this is not something that the healthcare systems generally in Europe have been focusing a lot about over the years. So that we also had a bit of, I understand there were some, not in our countries, but in Europe, there were recently some cases of, how's it called, ransomware. I think the most visible one was in Ireland, if I'm not mistaken, although I hear there were recently some others as well. So that is an area where I have to say I'm concerned, because when I hear that systems within hospitals have actually been hacked for ransom, then I am concerned, and I'm thinking that that's probably something we need to be very diligent about.
Yeah, so hard-pressed hospitals and healthcare systems need to invest in cybersecurity more. I mean, I've heard all sorts of things. Is that something that is putting off decision makers at local level, national level?
Definitely. In Germany, we have the Hospital Funding Act, which brings us 4.3 billion euro for improving the healthcare systems, IT systems in our hospitals. And it's mandatory that you spend 10% of this sum for cybersecurity. And 2 years ago, we even have the obligation for hospitals that are part of the so-called critical infrastructure to prove that they have more or less a specific level of cybersecurity. So that, of course, is a concern for everybody of us. That's one of the reasons why smaller hospitals really would like to have cloud providers for their data management. Because Charité, we have something like 250 people in IT, and we can afford to have 20 of them available for cybersecurity. If you look at a smaller hospital with 17 people in IT, there's virtually no one available for cybersecurity. So even there, we need other structures than the siloed databases in hospital data centers today for security.
Right. Okay. I don't know, Ms. Raffaelli, obviously the NIS directive included hospitals in the annex as critical infrastructure. Is there anything in the EHDS around requirements of cybersecurity, or will it depend on the NIS directive in terms of those requirements?
So what is the question for me?
Yes,
no.
yeah. No, okay.
I mean, the cybersecurity is not an exclusive issues in the area of health data. You know, I mean, of course, these data, as we all agree, are particularly sensitive, but the cybersecurity is horizontal concerns, and actually the ongoing, the existing proposals on the cybersecurity will fully apply also in this area. So we all the security and the cybersecurity elements would be also, let's say, considered in an horizontal way, not only specifically for this case. But what I can also add is that, of course, we have experiences in dealing with security environments in other sectors. The military one, and then other areas where the space related data, so that we do have experiences in this area, and we definitely going to work with those experts to maximize the opportunities for give guarantees of a very secure environment for the handling of this very sensitive data. We all agree on the fact that these are very sensitive data, and on that, maybe I take the opportunities also to say that for the primary use, for what it concerns the right of each one of us to deal with its own data, the proposal already foresee the possibility of let's say restricting the access to some of the information we don't want to share anymore. I mean, for instance, it could indeed be a mental health treatment or a case in the past, or whatever other case of information that we don't want to share anymore. So this possibility is already foreseen in the proposal for the primary use of data. So, and this is today creating a right that is not necessarily existing in all the member states.
Thank you.
Back to you.
I think Ms. Weiss, you wanted to add something.
Yeah, just to this issue on cybersecurity, that it doesn't fall down from heaven. It's not just something we say that we want and then we have it. It's something that's very expensive and very, very important. And that just underlines that one of the indicators I hope we will use assessing the political work around EHDS is that it must make the life science economy grow in Europe. End of story. Because otherwise we will not be able to afford the competent heads that else are working in other sectors in other continents on cybersecurity, for instance. So we need to make our economy more healthy and also bigger to be able to afford to develop the HDS within all its fragments, what is needed to be done. I mean, also the help to read your data. It's not enough to give my mother a cell phone and an app and then she can take it from there, although she is a nurse. There will also be the need for guidance and consultancy. And that is also something where we should be careful that we don't create an A team of citizens and a B team of citizens who cannot get the help needed to understand, to work with their own data in a personalized way. And that is also something that costs money. And life science sector is a very profitable sector for the society in terms of work and taxpayers and export return earnings from export. You know what I mean? So that's just underlining that is one of the arguments that we really must not overlook when designing this Rolls Royce of everything we want to have like that, without caring about where does the money come from to make that happen, and also to maintain and to continue to develop on the health data space, because it's not a one size fits all and then we don't have to care anymore on that. It will develop from now on and into the future.
Thank you so much. Did you have something to add to that?
Yeah, would like to add something to this. So in Germany, we also have the impression that just delivering technology and tools for patients will not be enough. And today we are more or less focused on data management and handling. That's okay, but we need an instrument to communicate with patients in order to deliver support and help. And when you look at your private surroundings, most people today use messengers for communicating and organizing themselves. And that's a good move from the German Ministry of Health last year to really bring a secure messenger for the healthcare system, like a WhatsApp for healthcare on the market that is based on an open source system, which is used by military in other countries and can be used federated, so you can have it on premise or in a cloud, but it allows collaboration like a standard messenger and even has interfaces to medical data sets. So that really will help us to have a communication line to the patient in order to support him while using such an app or such an environment. And I'm quite proud that that really happened to materialize only in something like 15 months. That we really had the first systems in place and they really work. And of course, no doctor would use WhatsApp to talk about patients, never. But we need something like a messenger. And those protocols are really affordable, open, and can be used even on a European level. And I would strongly recommend to think about how to communicate with patients in the future. That's not email, not fax or letters, is that one?
Yeah. I'm also thinking that, I mean, you can see on me, I'm not born yesterday. So I have been in the analog world of healthcare, working with paper journals. And I also have made my career in healthcare when we learn to use cross-disciplinarity as something that should make social workers, nurses, doctors, psychologists, blah, 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 everybody to work holistically around the patient. In that we are not yet done. We don't know exactly how to tailor and make to personalize a plan for a patient. By then giving the data to the patient, we should be careful that we don't make the patient the advocate for him or herself. What we failed to do in a multidisciplinary attempt, we should not then give it over to the patients and then, okay, you asked yourself for what you chose, given the data about yourself. So that's just an ethical and also a practical issue on the health data space that we must be somehow conscious and innovative about, because professional empathy is something that you train as a professional, but also in how to work together with the peers from other disciplines around the patient, saying, okay, you can read your data. The data tells us that we would like to suggest you to do X, Y, Z. And we would be careful not to use that in the digital jungle by saying the patient have all the data you like, and that's yours. Now, what would you like us to do the other way around? That's very
Valentina.
Just a quick comment. The reality is that patients do get access to information. They have built networks, and even though you try to make the best decisions for them, they will have their own opinion.
Yeah, of course.
And that's a reality. So the best way forward is to consider patients as equal partners in the shared decision making for the right therapies. Yeah, because they will do compare. I mean, that's also one of the purposes of H2O. They will do compare their condition to the health status of other patients. And they want for sure to go for the best treatment that they can have and have the best quality of life. So they will chase you. They will chase the doctors and the healthcare professionals if you don't get it. And that will be the reality. I mean, from a patient perspective, that's what we want to achieve. Make sure that they are aware of that better treatments are available and they can be made available by the systems.
There's no contradiction. No. Here is just that we must be careful on also on rare diseases there where you have minority groups of citizens that cannot create a great wave of concern or direction on prioritizing healthcare. That's just also a point of that.
Another also part of the discussions that we can have.
So there's a few questions that come in specifically on H2O. Some of them were covered, but maybe we can just go over again, which is the question around We need patients, we need doctors, we need data technology and research and industry. Are these stakeholders present in H2O boards, which I think you said there were?
Yes.
And then the second one was, will the needed investment in creating medical data steward roles within the medical ecosystem be encouraged as an imperative to the success of H2O?
Well, there are a lot of things which are very important for the success to H2O. So I'm not sure that this is where I would put my current thinking right now. The medical data steward within the medical ecosystem. I think hopefully this is something that will happen organically through the system, so that when the conversations become much more focused on the data, then there will inevitably be more need for medical data steward roles. But I think this is also linked, in my head at least, to this whole conversation we had about sustainability. Because if you create this ecosystem in a way that it's clear that it is sustainable, then you will be able to also improve, have the financing needed to have medical data stewards and other similar people who can help you do even more. It's a virtual, how we are going to create a virtual circle. That's the question. So if we are successful in the small thing, we will have encouragement, we'll have resources, and we'll go to the next thing, and then to the next thing. And I think this is what we are, that's the vision. Incremental change, incremental revolution.
Right, incremental revolution is a good one. Which I think partly answers one of the other questions, which was about could the H2O network and the HDS benefit each other. I think we'll be hearing.
Yeah, I think it's very energetic.
Does, could they even become one and the same?
Which is what I've covered in the beginning, because what I've said is that this concept of the H2O boards being the having this role of the custodians of the data and making decisions about the access to the data will not be needed if there is an EHDS board who does this. So, but what will always be needed is the importance of the boards to ensure the continuous standardization, if you will, of the outcomes and how they are being selected and how we continue having this common language between patients and doctors, and we collect the outcomes that will make healthcare meaningful. Because EHDS doesn't say which data, H2O says which data, and that is the difference. So H2O will become inevitably and hopefully a major data holder within the HDS ecosystem.
Yes.
Just a short comment on it, because I consider actually the H2O as kind of exam we has to pass to go further with the EHDS. So we need to succeed with this before going further on. If we lose trust,
exactly,
we've got a problem.
Yeah. In fact, that was one of the questions that I was going to ask you to lead on, which is, if the EHDS is in fact a success, what are the elements H2O beyond governance? What is the additional value it brings as H2O to the EHDS?
Living in a complicated healthcare system, I think we need to make it easier to be a patient. It needs to be easier to have the advice you actually want to have, how to access it. And we all need advices when we are sick, even when we are well. But we would like to go to the providers we prefer. We want them to be evidence-based. Although Elaine in the morning said that evidence-based, that was something in the 80s. Just to remind you, it's still here. We are prioritizing in the healthcare system based on evidence. But it needs to be easier for patients to have good advice. So that's could be part of it. Creating systems for giving good advice, digital, 24/7, impartial. whatever, you can carry on. We would like that, all of us. And the second thing is for the healthcare professionals, they are busy right now. It's a system under pressure. Perhaps something has to be let off. We will not do that anymore. And we'll need to create a easier work life for healthcare professionals. So they need advice as well. And it's not enough just to have data. We need to make knowledge. And then, as you mentioned, Peter, we need to make a difference in the real world. It's not enough just to discuss, bring data in front and create the knowledge. We need to change real world for patients and for physicians, nurses, whatever.
I don't know if you have anything to add to that, Dr. Gokul. What's next for you? I mean, we're only just launching formally H2O, but I mean, how do you see it in 5 years' time developing? Is that looking too far in the crystal ball?
It might be. Well, if you look at the German healthcare system, that's not developing so fast. So 5 years is not that long. I hope that the differences between structures like the EHDS and H2O structures will be lower, because that should really end up in a joint solution. Because we need one ecosystem with, of course, multiple facades, but we do not need so many parallel systems. But if I look at both systems today, I think there is a good chance for convergence.
Super. And I don't know, Ms. Raffaelli, with the EHDS discussions well underway in the Council amongst the 27 member states and about to start in the European Parliament, what's your perspective about when a functioning EHDS will be feasible and in place at European level? And will it be a multi-speed one?
Yes, it's a good question. Of course, we are working very hard with the Council and with the Parliament, indeed, to try our best to finalize the adoption of the proposal still within this Commission mandate, because we think this is possible and will actually create a much more certain, let's say, process for the implementation afterwards. The transition arrangements we mentioned before, in our view, they are realistic, but of course we know that this is going to be one of the points for conversation with the co-legislators. So we'll be, of course, very attentive to that conversation. And what we wish is a system that at the end will deliver. So I think this is going to be the Commission will play its role of good negotiators, but also keeping very much into the center this need of being realistic and very pragmatic. So in creating a set of rules that will make the difference for the citizens of tomorrow. So we're looking forward, of course, good cooperation with the co-legislator, but also indeed as with project as the one you're presenting today, H2O, because I think it brings quite a lot of content, suggestions, good suggestions and content to the discussions we're going to have in the coming months.
Well, that's good to hear. Maybe I can turn to our two parliamentarians. I mean, what's your vision in terms of one, how quickly the Parliament can deal with the EHDS proposal? And secondly, do you have a view of when it could be up and running in a meaningful sense, building on projects like H2O?
That's a very, very good question. I said to my party last weekend that I'm willing to run again in 24 for a second term. And I think also in the second term after 24, we will be working on this file to be realistically, because now we are informing our positions towards the trilogues on this file here, this very important file, and then they will be entering into force afterwards. So I think we look into some year after 2024 before we see something that is actually delivering to the physicians, to the healthcare professionals, and especially to the patients. But I would hope that we already see that the way we design it also delivers interests from life science innovators and entrepreneurs and investors, that they say, okay, we stay a little while in Europe and help to fund what is needed to be funded in different ways to make the EHDS also deliver on that level. And my judgment is that what could be fruitful for the debate on that is that we design the Rolls Royce that we all would like to see, but also that we see how to maybe cut it down into puzzles where we start with first things first. And then we build upon that. Also, because we have 27 different member states on different levels, we need everybody to come on track, maybe in a pragmatic way, as you also said, from the Commission. I think that would be a good approach. So not scare everybody away by creating a monster that is some kind of a silver bullet, take it or leave it, or that we do it as a staged model. Also to become wiser. I mean, we are a continent of positively meant doubters, and by that, we also get better and better and better, refining on what we deliver and how we deliver.
Thank you. I don't know, Mr. Breyer, before you go, I know you've got to go. Do you have any thoughts about the EHDS, how quickly it can be in place in terms of the proposal? But then secondly, how well functioning it can be? Is it going to be a big bang, or is it going to be an iterative process, as Pernille has suggested?
I would like to agree with my colleague that regarding the timeline, which we haven't discussed in Parliament yet, we should not be pressured by the 2024 elections. You know, if we don't take the time to get this right, this will either not be possible to implement. It will either get stuck at the implementation stage, which is really extremely complex, because hardly any member state has anything like this in place, or it will simply not be accepted by the patients, by those that will be involved, treatment providers, etc. And so if we want this to work, we need to take the time to design this properly. And yes, I wouldn't dare a prediction. It all depends on the negotiations. But I think that the political discussion process will not be the longest part, or before this will be up and running and implemented.
Thank you.
I
I don't know, is that disappointing for the other stakeholders?
Well, as a German, we are quite patient, but even I would like to have it earlier. And sometimes it's better to start with a good plan today than with a perfect plan tomorrow.
Exactly.
And you're right, you shouldn't make a mistake and kill the project at the first week. But you can start with a small step that is not critical, but you have to start once. There's a time for discussion and there's a time to act. And I think now it's time to act.
Jørgen?
Totally agree. And I think we learned something from the COVID-19 crisis, that we acted. Somehow we stopped talking and acted because it was necessary. Perhaps we should remember how when we're under pressure, we can act.
Exactly. And if we then make mistakes, we can correct them.
Yes. We're used to that.
Yeah.
And what about you, Valentina? Oh, Valentina, what about you from a patient point of view?
I tend to agree that we shouldn't feel the pressure as long as the work is well done. We need to prepare the stakeholders. We need to prepare healthcare systems for this transformation. And so that's where I think we need to be pragmatic. I'm not saying that happy to delay, but let's make sure that things are well done. I don't want to end up with a new situation like the medical devices regulation, where it's supposed to be implemented and the discussions are restarting again eventually. So that would be difficult to accept from a patient perspective.
Yeah, I understand. And lastly, Minnie, can I close with you? What's your feeling about the EHDS and how HDO can continue to contribute?
I think H2O has a different legal basis, has already a legal basis, which is patient's consent, so can continue irrespectively, and hopefully we will prove that by creating the appropriate governance and creating the appropriate trust, we will get the consent, and therefore we will be able to operate. So, and hopefully by that, we will create a momentum that will make some of the discussions in the EHDS easier, because maybe some of the of people's fears will actually be addressed through some practical implementations. So
Well,
hopefully we can help make things faster.
Excellent in a practical sense. Two speeds, one at the practical project level, which is H2O, which will move very fast ahead, I'm sure. And then we'll have the legal framework at EU level, which will come in due time. Thank you, everybody on the panel virtually, Ms. Raffaelli and MEP Breyer, and here each of you in front of me who have created a very interesting discussion. And thanks very much on behalf of the audience.
And thank you.
Right.
Thank you very much.
I have a last word.
Oh, you do?
I do. And my last word is that I would also like to mention and thank IHI for this project, because this is a public-private partnership, and I think it is actually a very good example of how initiatives which are public and privately led can create interesting experiments or public policy experiments that Europe can also build on. I think we are probably a relatively unusual IHI project, but I think it's potentially interesting to see us to create a precedent out of what we're doing and have more of us coming. I know that Angelica is here, and I would like to publicly acknowledge all the support we are having and our gratitude for this, because we wouldn't be able to do what we're doing if it wasn't for the IHI or IMI, which is the way we got it. Thank you. That was my final comment. Thank you.